So I think, shall we go ahead and start with the meeting? Am I audible?
Yes, yes. Madam, we can start actually. Shall I start, madam?
I think we can start. Yes, sure.
One second. One phone.
So
we'll start.
Welcome and good evening, and let us once more welcome everyone to this session on contraception, Viva in obstetrics and gynecology. And for the upcoming exams, I'm sure all our postgraduates are going to benefit a lot from these sessions, and especially the last two ones have been viewed so many times by the postgraduates, and I'm sure this is going to be another helpful session. Today we have our eminent teacher, the master teacher, Dr. Aswath Kumar, again to enlighten us about the newer developments and all the drugs and other specimens regarding contraception. We all know he is the professor and professor of obstetrics and gynecology at Jubilee Mission Medical College, Trichy. He is also a trained oncologist and a laparoscopic surgeon, and he has been the past FOGSI Vice President of 2019. He is now known to us as the teacher of all teachers. And so let us hear him about contraception. And over to you, Dr. Aswath. Let us go ahead.
Thank you. First of all, I thank Cochin Obstetric and Gynec Society as well as Rita Madam for inviting me for this. And always, as you all know, teaching is my passion. So, so how many classes Rita Madam wants or you people as PGs wants, I don't mind. Only the time permits according to my convenience. I am ready to take. So more before the exam, any topic you want, you tell Srilata Madam, so that I will be able to discuss that topic with your postgraduates. Anyway, without wasting time, today I plan about 1.5 to 2 hours session. Let me see whatever there are so many things, new developments are there in contraception. Let us go through the Madam, can you see my slides?
Yes, you are very much clear. We can see everything. Yeah, now it's fine.
So
everyone, please mute yourself and kindly make sure that there is no unnecessary interruptions. Any question answers can be dealt with at the end of the session, or you can. This is the chat box.
And one more thing. See, as the rain is going on, in between, in case my connection goes, you have to wait till my connection comes back. So it may take 1 minute. Okay. So don't run away from the thinking that I have stopped the class. So that is because I am the only speaker here. So you may have to wait patiently in between if my connection goes because of the rain. Okay. So there is a chance that in between connection go and come. So you patiently wait. So thank you in advance for your waiting period in case. Hope that it will not go. So contraception. Okay. This is some topic. See, for exam point of view, if you take one full Viva session, that means the Viva table is divided into 4. In most of the exams, one full Viva is contraception. And that means 25% of the marks in a Viva session is contraception. More than that, contraceptives are kept in OSCE also. So for a DNB student, OSCE is very important. In that OSCE, you may get some points. So I have included all the latest developments so that if you listen to the class properly, at least you can, when you hear the name, at least you can say. When you say about a contraception, the things which are very important in a contraceptives are what are the different types of groups of contraception, or for example, if you take OC pill, what are the different types of oral contraceptive pills are available, and their mechanism of action and their indications. Other indications other than obstetric contraceptive indications are there. Their complications, contraindications. These are some of the things for almost all the contraceptives. So that naturally, and some questions which are practical questions are asked for the exam. So I have taken all these things and newer things. So if you answer most of the things which are given in the textbooks, they may ask you some new things which are there. So I am starting the class. Srilada madam, you make the people enter. Now also people are in the waiting room. So please, please make them enter into the, okay. Okay, starting the class. So first, this is the first slide. Very common question. Condom may be kept. So it's a male condom. Okay. So they will ask you certain things. What material it is made up of? Usually it is made up of latex rubber. It can be made up of polyurethane. It can be made of silicone rubber, and sometimes even natural membrane, that the lamb cecal pouch is used. The problem here is in a lamb cecal pouch, it has got micropores. So the main advantage of the condom goes, see, what is the additional advantage of the condom? The first question answer should be, it prevents STD. So coming to the next question will be, what are the advantages of a condom? So condom advantages, I told one of the most important advantage is STD, protection against HIV and STD protection. Other things which can be, we say that it's safe, effective, less expensive. Less expensive is one thing. No medical help needed, and ideal for couples with infrequent intercourse. So infrequent intercourse couple doesn't have to use a hormonal contraceptive. So it is ideal for couple with a infrequent intercourse, and also useful. There is no contraindication in lactation. And two things which you have to remember is that STD, HIV, and cervical cancer. So when a question suddenly comes, condom prevents which cancer, suddenly you should keep in your mind that it allows, it prevents HPV, and it prevents cervical dysplasia and further cervical cancer. So this is the advantage of a condom. As it has disadvantages, yes, it interferes with the pleasure, and there can be breakage if you use it perfectly. Otherwise, it is 12% actually. If it use it perfectly, it is 2%. Actually, if you say it is failure rate is 2% of perfect use. Hypersensitivity reactions may occur. There are people who are having allergy to condom, so they cannot use it. Non-reusable, that is a problem, must be used with every act of coitus. The question which is more asked is that immediately when you take a condom, they will immediately, will not ask about the contraceptive use, everybody knows. So they will ask you, what is a non-contraceptive use? Non-contraceptive use, you all know, condom catheter for a PPH. Male catheter, you know that condom catheter for a male catheterization. Transvaginal probe, prevention of STD, and in premature ejaculation to collect sperms, actually collect the semen for IUI and other procedures. So these are the different, and what is the available, Nirod, what is available free of cost in the government hospitals. The failure rate is usually, they say 18%, but perfect use, I told you, failure rate is 18%. And you, there's a picture showing how a condom is used. All these things, an erect penis, a condom is one. Only thing which you may not say is that compress the tip. There is a reservoir like a part in the tip. Compress the tip while you insert, and while you take it out, be careful. Hold on the base, otherwise it spills into the vagina. That is enough for pregnancy. So these are some of the, see, when you ask it, you may think that it's a very simple question. How do you use a condom? And maybe to make fun of you, they are asking nothing. There are certain points which you have to tell your patient. That is the only reason why they have been asked. So the important things in a condom which are asked is that non-contraceptive use. That is it. And prevention of STD, HIV, and HPV. So these are the things which are very important about condom. And Nirod, what is condom? Which is, and they may ask you the failure rate. You can say 18%, and if you perfectly, if you use it, it can be better than even OC pills. Okay. What are the new developments in condom? See, we have come to lubricated and non-lubricated type of lubricated and non-lubricated, lubricated and non-lubricated, condom with spermicides, latex condom, non-latex condom, varying size and standard, color, favor, all these things. As you all are students, most of you are students from Kerala, they will be asking one question. What they will be asking is that, see, were HLL, Hindustan Latex Limited, is the Indian company which is in Trivandrum, which is the company which produces maximum condom in India. So they will ask you this question. So please, when you are not the DNB students who go outside for exams, but to students who are there, just to know that you know this thing, your general knowledge is there, they will ask you. Latest updates of condom. Imagine, see, these are all things you just have to remember. Once you have heard STI condom, that is means it detects STD. It detects STD. Just hold on. Just I have a call. Hello. എൻ്റെ അമ്മേ, ഞാനിവിടെ ക്ലാസ് ഇതെടുത്ത് കോൺഫറൻസിന് ടോക്ക് കൊടുത്തോണ്ടിരിക്കുക. പ്ലീസ്. ഓക്കെ 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 ശരി ശരി ഓക്കെ 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 ശരി ശരി ഓക്കെ ഓക്കെ. Sorry for the interruption. My mother had called. That is the only reason I took the phone. Otherwise, I would not have taken the phone. So, STI condom, layers of molecule detect bacteria. So this is nothing. See, when there is an STD, STI is detected, it glows in the dark. So imagine that. Then skin condom, very thin non-latex condom made up of polyisoprene, softer, more firm fitting structure, more resistant to self-lubricating and biodegradable condom. So it's a biodegradable condom. Hydrogel is another ultra strong skin-like prosthetic tissue, very strong condom. So these are some of the condoms which are coming to others. It's a male contraception. So you can have Gossipol, the Chinese, it's something like a retinoic acid receptor antagonist. So epidermal protease inhibitor, which is a key molecule test. What is the action if they ask you? Male patch is there, like a female patch, male patch is there. That is what is called adjudine. So derived from anti-cancer drug, lonidamine, whatever it is, it's basically, it develops, causes developing sperm cells to detach from Sertoli cell that mature from before. That is why finishing maturation. That is what happens. So 1 or 2 doses of adjudine can prevent conception for a month or more. So the principle is that it takes about 64 to 72 days for a new cycle of sperm cell to develop. That is the, so once you have inhibiting it, so we get protection for 72 hours. So this is condom. This is a male coming to. Then there are vaso-occlusive devices. And this, the most important is RISUG. It's developed in India itself by IIT Kanpur students. We don't have time, so our engineering friends are helping us with research. Reversible inhibition of sperm under guidance. That is, it's reversible. That is the most important word. Reversible. So, so it involves injecting serine malic anhydride into the vas deferens to block the sperm. Can be reversed with a shot that breaks the gel. So this is how it is, very simple. This is also can be, it's the reversible type of, so non-surgical reversible vasectomy. See, so they will ask you in the exam, have you heard about something reversible vasectomy? So it is not that the reverse vasectomy, non-surgical reversible vasectomy. So this is another name for RISUG. Okay. This is another compound which can be injected into the vas deferens. So it's called Vasa gel. As it is injected into the vas deferens, it's called Vasa gel. Okay, you remember. Nothing you remember is that what is injected? It is DMSO. So it forms a gel and it reabsorbs, and the sperms are get blocked, automatically get reabsorbed into the body. So it's a Vasa gel which is injected into the into the was difference. It is DMSO. Then there is another thing, sperm switch implant valves are there. There's an electronic valve which is implanted in the spermatic duct, open, close. Okay, it's only 2 centimeters long. It is implanted in the testis and involves less than 30 minutes procedure. It's also a simple procedure. Don't think that it's a very complicated procedure. So these are the latest developments. Then we have newer spermicides. Okay, C films are there. You all know nanoxylone 9 and octoxinol 9. There are so many other PRO 2000, Caragard, cellulose sulfate gel. You don't have to learn. See, at least you learn nonoxynol line, all these things, form aerosol, scrollum T, and just this picture you have in your mind, anything asked about the male contraception, if you are able to mention in your theory exam, also a male contraception being asked, you can write all these things, 1 or 2 for tenofovir. Tenofovir is another which is always Sills diaphragm. I will tell you, it is along with Sills diaphragm they use tenofovir. Tenofovir also can be used as a new spermicide. Tenofovir can be used. This is what is called the C film, which gets absorbed into the vagina. C film. It's a non-oxynol 9 C films. Okay, non-oxynol 9 C films are there. So this is how all these things are. So this is the different thing. So what today what we have about, before going to the second question, so what we have learned today in the first question is that, see, condom, we learned about what is a normal condom, what are the advantages, disadvantages, other indications for condom. Then we just went through some of the things, what new has come in the condom. HLL I told, then stye condom, skin condom, hydrogel I told. Then we told about Gosipol and something called new thing, something called male patch, which is called the adjudine. Male patch, which is called the adjudine. Then we talked about the vaso-occlusive devices, RISUG, VASA gel, sperm switch. Then we told about the new spermicides that are also available. So these are the things which told about condom. These are the common questions. I don't think anything else. I'm trying to complete each session and going forward. Now we go for the next is a female condom. So this is a female condom. Female condom, you can see the female condom. It's by common names are Femidom. Remember these names, Femidom, Velvet. So this is a, see, if you take a female condom, how much it is? It's a 15 centimeter long, 7 centimeters diameter. It has a vaginal ring and a cervical ring. So the cervical ring is fitted inside. So it's a thin, soft, transparent, loose fitting polyurethane plastic bag like device that lines the vagina. It's actually, it is little big actually. So this is how it is being applied. So you put your hand inside, you put it into the cervix and just push it in. So the closed end, one end is open and the cervical end is closed and the other end is open for the entry of the penis. So this is how, and this is how it is fitted. Okay. So you have, now coming to what is it made up of? It is also made up of polyurethane. It is made up of, I told you both ends, I told you. You remember these terms, Femidom, reality, velvet. Please remember this too. So see, the examiner wants to know that, see, not that you know everything about female condom. They want to know that what is in the market. You cannot write just female condom, nobody will get. So they will ask you, like, you know, Novelon, Femilon, like that, you know. You should know at least 1 or 2 terms. So they told you what name it is available in market, like LNG, IUCD, we say Marina. Like what term it is available in market. That is what Femidon, reality, velvet. Okay. Now coming to what is the advantage of a female condom, which has the same advantage of the male condom. Method, the most important advantage is that it's under woman's control. So these were used especially in prostitutes distributed in red street areas in Calcutta and Bombay, where the males otherwise may not wear the condom. To prevent HIV and STD, they were given. So remember, like that, it was given in prostitutes. So you understand that is under woman's control and it prevents STD and HIV. As it is thick little, like male condom, the breakage is here, it is less. And see, you can place it It can be placed 8 hours before the intercourse. You can place it early and anytime they can have intercourse. If I do not that at the time of intercourse, you have to keep it. So it may take some time to keep it. So effective against STI, we told. What is the disadvantage? The disadvantage is that, see, what is the disadvantage is that it is expensive. Actually, that is the most difficult. And the woman needs proper motivation. This is the way it is being, the upper end being, you can see here, squeezed, and then it is put inside, pushed inside. So this is how it is done. Okay. So expensive, woman needs motivation, difficult to insert and remove. Can be used in women with pelvic organ prolapse. Pelvic organ prolapse also woman can be, it can be used. Failure rate, so it can, you can fix it in and push the cervix inside. That is what they do. So failure rate is 20%. The failure rate is high in these cases. Failure rate is high in these cases. So what are the advantages? We told all the advantages we told. Disadvantage, the cost and difficulty of insertion. I have made it a little more easier. And so the advantage, if you ask the advantage which is asked over male condom, the most important advantage you can say is it's more stronger, the breakage is less, and it is under woman's control. So these are these are all simple questions I asked. What is the advantage of a female condom? So suddenly when you listen to the question, you may not understand what they are meaning. Meaning is very simple. It is stronger, so the breakage is less, and it is under, woman is having the full control over it. So this is a disadvantage, is naturally cost, and it is difficult for insertion. You have to train the woman for inserting it. There are also updates. So each I am telling the updates. So male condom, I told you the updates what are happened. So many updates are happened on a male condom. Like that in female condom also many updates are there. Easy to use and protection. So it has come. It's called the woman's condom. So it is made up of polyurethane, has dissolving capsule for insertion, easy to insert and remove. Water-based lubricant is used nowadays with less interference with sensation. So oily-based, the sensation decreases. So water-based lubricants are used. So these are the developments in a female condom. This is an FC2 latex condom. This is a latex female condom. This is something called an invisible condom. You can say it's a sodium lauryl sulfate polymer. This is how you can take this screenshots or see this video. All these things I don't want to explain, sir. You can see it's like a gel, which is a Cerviprime gel, which you can take the cap and insert like that, and the gel is being pushed inside. It gives so the patient can herself push it inside the vagina. So this gives a layer over like a condom. This is how this is called. Another new thing which has come is that origami internal condom and panty condom. So origami internal condom, you can see the picture here. Origami internal condom made of formulated nitrile polymer and high tensile strength and durability. Okay. Panty condom is another reusable panty, 100% nylon, and holds condom in place. You can see how that panty is specialized to hold the condom in place. So this is about the, so we learned about female condom. What is female condom? How do you insert? What are the advantages of female condom? What is the advantage over a male condom? What are the disadvantages? And what are the modifications? So many modifications you saw. At least you should see, you should be able to name 1 or 2 modifications. So I want all of you to score 100% marks. So when something you see in certain exams, if you see, they will be, all the examiners will be sitting together and conducting the Viva in most of the places. So Viva may not, as you think, Viva may not finish in 10 minutes in a post-graduation. Viva may go on. So 20 minutes is the Viva, they say, means it may go on. So maybe they may not ask on other things. The contraception is a definite question to be asked. So you may get a lot of questions, and it will, all these small things, if you know, it will give an opportunity for you to score good marks. Okay. Now coming to, this is what is called a cervical cap. So you identified it as a cervical cap made of silicone or rubber, designed to fit the cervix and remains in position by suction action. It goes inside. So you can see here, if you see here, you can see the see how the cervical cap is being kept. Okay. Basically, it is kept only at the cervix, so it cannot prevent HIV. It can prevent, so cervical cap and cannot prevent HIV. cannot prevent HIV. So it cannot prevent HIV because HIV enters through mainly enters through the aberrations in the vagina. It covers, but it can prevent STD. Okay, so that is the difference between a cervical cap diaphragm and a female condom. So it can be also introduced 8 hours before intercourse, and the advantage is that it can be kept for at least 8 hours after intercourse, and it can be kept in place even up to 48 hours. So these are the advantages. If there is no intercourse, you can keep it up to 48 hours inside. Provides continuous contraceptive protection for the duration of use. Can be left place for 48 hours. That is very important. It can be left in place for 48 hours. Disadvantage here, patient cannot, like female condom where the patient can be trained. Here patient cannot be trained and requires high degree of motivation and cannot be used in prolapse patient. You keep it outside, it will fall off. So female condom can be used in a prolapse patient. Here it cannot be used in a prolapse patient. Coming to the next barrier method, this is what is this? This is a vaginal diaphragm. So it's a spherical dome of various diameters of latex are available, determined by vaginal examination. Like you put a ring, pessary, here also you do a vaginal examination and you take it by trial and error method. You know that which diaphragm will be fitting properly. Placed in the vagina to cover the cervix. Rim is placed in the posterior fornix and anteriorly in the cervix, like same like you could put a pessary. So if you are knowing how to put a pessary, it is not difficult to put a vaginal diaphragm. Combined with spermicidal gel, I told you there are combinations of Sills diaphragm with tenofovir and all these things are there. Time introduced at least 3 hours before the intercourse. Here it is 3 hours, but the other was 8 hours. Here it 3 hours before and at least 6 hours it can be. And it cannot be left more than 24 hours, not more than, other was 48 hours. Small things are there which you have to learn. What are the disadvantages of a diaphragm or a? So both are safe and effective reversible methods of contraception. Shift the contraceptive control to woman. That is the most important. So here the woman has a control. Reusable up to 1 year. All these things can be sterilized and reused up to 1 year. Can be placed before intercourse. Disadvantage is that all these things I told you, high degree of motivation, patient more to UTI and vaginal infection if you leave it behind for a long time. Must be used with a spermicide to better protection. Does not protect against STI and including HIV. HIV is more important. It can protect against STD, but HIV is more. This is how does a Sills diaphragm looks like. Silicone, actually Sills means it's a silicone diaphragm made up of silicone. Okay, has an arching ring, so you can take it out like this. So that is the advantage of it. So it's another wide silicone diaphragm is there. So different types of silicone diaphragms are there. So here this end is being compressed like this. I can, if I was having one, so gel is applied inside and just compress like this and then put it inside and release it. So it sucks into the, attaches to the cervix up like this. So these are the different anterior, posterior. You look, which should be kept anterior. That is what. So if you have shown, if in an exam, if in a DNB exam, if there is a Sills diaphragm and then they will ask you one small point, which is anterior and which is posterior. So at least they want to know that you have seen this, or you have kept it. Okay, kept it, nothing. You have seen this diaphragm. I don't think it is not popular. I don't know. So some of your consultants who have traveled outside or who have got some samples may keep it for your exams. I don't think it is routinely used in India. I have seen one, but I have not used it personally to any patient, given to any patient. So that is about the Sills diaphragm. So now the whole barrier methods are being covered. So what are the things we covered in barrier method? We covered male condom, female condom, spermicides. We covered different types of spermicides. We covered. Then we came to diaphragm and cervical cap. These are the 5 things that you can kept for the exam. Okay, I will not be covering anything about natural family planning methods. Actually, in this class, there is no time, and usually it is not asked in your practical vivas. Coming to this is, if you see this, it is 380A. The classical identifier is that you can see copper at the arms. A stands for, and another question which is asked is that in 380A, A stands for arms. Okay. So this is a very important question, practical. They ask you, so what does it A stands for? So many people tell many things, but you should understand that it is A stands for arms. It is in the arms, it is there. So this is one of the most important thing which you should. So they will say that, and you should know what is called a lark. What they say, name one. When I as an examiner I went to one college. So the co-examiner asked, tell me something about lark. Poor student knows everything about contraception, and the examiner was not ready to give the full form of lark, and he was pestering the student, telling that you don't know lark, and all these things he was telling. So I was feeling so sad that then finally I told. So he was after the student when he no, you should not. They should have known what is called lark. Lark is a long-acting reversible method of contraception. The most effective lark. See, other larks you can say Implanon and other larks, example which I told you. So this is the one most important and the most effective long-acting reversible contraception. So when you have copper teas, there are two ways of we have banded copper tea. Banded means is a limp. You can see the bands here. It's called the banded copper tea, and these are no bands are there. So it is called the non-banded copper tea. So at least you should know what are the banded copper teas and what are the non-banded copper teas. Banded in this 380A, 380 slim and flexi tea. These are some, and only basically, even if you don't banded, you say the example of 380A is okay. Non-banded, you say the example of multi-load, at least. I'll teach you say the example of multi-load. This is more than enough actually. So today, small things which you have missed, I am telling you, which are asked in an exam. So I know everything you know, but the problem is after when the examiner asks you, what is a banded copper tea? Name examples of banded copper tea. You know everything in IUCD, but you don't know what is called a banded and non-banded copper tea. Now coming to see what be the most important 380A. So 388 is the copper that is being kept here. T-shaped copper containing IUCD. So we can say it's a copper containing IUCD and warped around 314 fine copper wire and each arm 33. This is a quiz only. This may not be asked. How I remember is that 333. You can remember in the limb and 33 on each copper arms each arms has 33. So 333 and 33 in each arms. This is how I remember for the quiz. But this is not needed actually. If somebody asks you, you can sell. So I told you all this. It provides two strings at the base. And base is round ball. It prevents perforation and through the cervix and composed of polyurethane integrated with the barium sulfide, that is polyethylene, that is a structure material with which it's made, available along with a plunger and a preloader insertion tube, and the most important is lifespan is 10 years. So certain small things, perfect use 0.82 and a typical use it is 0. So they will ask you if it is a typical use, what is the failure rate? It's a perfect use, what is the failure rate? See, failure rates are different in different books. So don't quote me. These are all I have taken from certain books, common things. So I remember that 0.2 for a 380A, which is perfect use. And it's only a typical use, they say that it's only 0.8. Now coming to see the very common question, the copper tea. So they will say, what is that? So it's simple. It is gametotoxic to sperm as well as ova, prevent fertilization due to local inflammation. So this word has to come, local inflammation. So it creates a septic inflammation inside the endometrial cavity, and that is what. So the endometrial hostility leading to failure of implantation, and it is toxic to the blastocyst. It's toxic to the blastocyst. Coming to what are the contraindication of a 380A or any copper tea? Pregnancy, you have to rule out before you insert copper tea. Puerperal infections are there. PID or puerperal infection, sepsis is there in a patient delivered having fever and puerperal sepsis. You cannot insert a copper tea. Whenever a patient is having an unexplained vaginal bleeding, make sure that nothing is inside. Okay, even you are not dealing with a cervical cancer or an endometrial cancer, CA cervix, CA endometrium, current PID, and AUB with distortion of. So this is same with everything. See, in your exams, many times we hear all small like not for contraception Viva. When you sit for the other Viva and you are having multiple fibroids with a patient with fibroid, you have palpated up to umbilicus. Imagine, with multiple fibroids. And when you are asked treatment, so they may say that, okay, patient is not willing for hysterectomy or something. They may say anything else. No use of telling Marina there. So it is not for when a cavity is totally distorted. Most of the time, this Marina or LNGIU is not going to act. So whenever you are putting intrauterine devices, one of the most important things that if there is an AUB with distortion of uterine cavity, it may not be of no use. Best time to insert. Everybody asks you, when will you insert? The next question. 2 to 3 days after period. That is the most important. Easy to insert. See, another point you have to learn is that during lactation amenorrhea, anytime within 6 months, after 6 months, make sure that she is not pregnant. See, maybe in so whenever she is in lactation amenorrhea, anytime within 6 months or after 6 months, whatever you do, please make sure. Even after 3 months, I have seen patient coming pregnant. So you have to make sure, do an UPT whenever you are putting in a late stage. Post-abortal means after doing MTPC. I still remember when within immediately following, because when I studied in BJ Medical College Ahmedabad, there what was it? There were so many patients coming for MTP there. So there was an MTP OT, minor OT was mostly MTP. So young girls, college going girls used to come for MTP. So my sir doesn't want to do MTP for unmarried girls and all. So sir, what sir used to tell them is that I can do MTP, but I will put copper T. So this was what, so naturally the patient will go away to some other place. So as you avoid him, or he will say that I will do sterilization for you. So this is what he used to do. So I still remember that, and all the cases MTP was done in neighbor. For example, she has children, unplanned pregnancy was there, and then we used to immediately, we were given instruction that after doing MTP, immediately you put a copper T. It was an instruction which was given to us. So I always remember, post-abortal immediately you can keep. Within 12 days, no backup is needed. Okay. So only thing is that whenever you put copper T, you have to rule out infections. Okay. Now, coming to PPI UCD, we will deal to it in detail. Postpartum contraceptive placed immediately following delivery, following the delivery of the placenta, during cesarean or within 48 hours following childbirth. I will tell you details about it. It's a very common question which is asked. Then it can be used as an emergency contraceptive within 5. So all these things, see, it is not simple. When you are asked when is it, so you should have 1, 2, 3, 4 like that. See, you should tell that interval when you say that 2 to 3 days after periods, in lactation amenorrhea periods, or after 6 months, you have to make sure that she is not pregnant. Post-abortal, immediately you can put, or within 12 days you can put. PPI UCD is there, you can put immediately after delivery placenta, during cesarean, or within 48 hours. Emergency contraception means it gives excellent within 5 days of unprotected intercourse. Not-touch technique and withdrawal technique is which is used. Okay, this is another, another thing, see, they will give you a copper T in your hand and ask you to put. This is not the way you are doing not-touch technique. See, I will show you how it is done. See, first of all, when you are asked the steps of, so clean the cervicovaginal cleaning, very important. You put a cusco speculum, you clean the cervix. Then, see, open the pack at the, you can see here is the copper T, see, and you are opening the pack here. So then what you do is that, then you hold the pack, see, hold the pack here, see, hold it here, open and hold it here, pull the stillet little out, open and pull it here. Then with your hand, you are inserting it inside. This is many times, the students are asked to show these things, because you go and work in a PHC, you may be having to put lot of, so you will be getting free 380A and you should know how to put it. So fix the arms, push it into the tube, then IUCD to go into the uterus, ready. Then you take it out and push it inside. By withdrawal technique, you can take it inside. So this is how you can put. Now, this is another question which is asked, is that, so 380A is the commonest question. All these things are about 380A. So we told about 380A, everything from A, what stands for, to how many copper is there, how is it inserted, what is the mechanism of action, what are the indications, what are the contraindications, everything you have learned. Okay. Now coming to, this is something else. This is another common which is obtained. So most of our private hospital and all, many times 380, instead of 380A, we insert. Most of the time when we ask our hospital, when the patients get this multi-load. So multi-load 375, it is what we get. So it's a copper revising device made up of polypropylene. So I told you it's a non-banded, remember the word non-banded device. Banded, not bonded, banded device, non-banded device. So copper releasing device made, so that we told you, arms are flexible. So when you put inside, it turns like this and then goes inside. You don't have to just push it in. Yeah, as usual, it is radio opaque and radio translucent. Recommended for 5 years. 5 years is the 3 to 5 years. Okay, you can say 3 to 5 years. Maybe provided with a preloader or inserted without a plunger. So you just have to, here there is no plunger. So what is the difference is that there is no plunger. You just have to push it inside. You take the inserter tube out. It goes inside. So it is very simple, easier to insert than a copper T. You don't have to have all this notch technique and all these things are there. Coming to a non-hormonal copper medicated, we told 380A comes. There's another which you have to call CU Safe 300. It's a T-shaped with flexible, flexible arms. Okay, flexible inward curved arms. So what is the advantage of inward curved arms? It decreases uterine irritation. So one word only you should have to learn. It has a monofilament tail and it is welded into a shaft to reduce ectocervical abrasion. So these two things are inside, it is welded. So it's in the center, it is not attached to it. So these two things are copper. That why it is called, that is why it is called safe. CU Safe. It is safer than the other copper T because it does not cause the endometrial irritation is there. That is a chance of expulsion involves more when there is irritation. So decrease the expulsion. They have bended the arms down. This is another way of bending it. Fincoid 350. It's a plastic skeleton with a curved horizontal arms. And see, you can see how this is made. Modification to resist accidental. It will attach like this so that it will resist. See, if you keep it like this, easily it can be here. It will be difficult to push it down. So this is another soft T. This is a soft, very soft. Flexible knobs, you can see the occlusion. So these are Henry. This advantage is that here what they want is that it will go into the fallopian entrance of the fallopian tube. It's very soft, so it will it may block the fallopian tube and prevent ectopic pregnancy and infection. So everything, so many modifications. You think about it. See, actually speaking, we all can modify things like this. But we are not taking time. So once you read this contraceptive chapter, I am sure that at least one of you sitting in this, listening to the class, will be able to modify all these things. So, and make it more friendly for the patient. Then multi-load Mark 11. This is another updated version of multi-load. The modified new inserted design has a diameter which is original mode and prevents intrauterine device from getting pushed beyond the inserter. So it has a block. So previously, when you are using multi-load, you don't have a control. You push it inside, it goes inside. Here there is not a control. So this modification limits the risk of uterine perforation. So every modification, you learn the heading safe. What is safe? It is softer, it doesn't irritation, the expulsion is less. Then what I told, fincoid, it's curved upwards, so the expulsion is less. Here it is a soft T. That means it has a small, it will go inside tube and it may even block the tubes. Okay, so these are some of the and it is to see to modifying multi-load. Imagine imagine that how they think. So multi-load, you push it inside without any control. So it goes inside. It can even perforate the uterus and go out. So to prevent perforation, the modifications are there. Coming to the most important question which is asked in IUCD is this is what? So this is LNG IUCD, and you call it by pet name Marina. Marina. So, so what is Marina? They will ask you certain questions. How many levonorgestrel is there? 52 milligram. Daily, what is the release rate? 20 micrograms. Okay, 20 micrograms. It's a blue colored monofilament thread is attached to the loop device, and it is the radiopic. That is why it is attached. The lifespan is 5 years. So that is another question which is asked. 380A is 10 years. Here it is. So what is the additional mode of action by, so the change in cervical mucus, this can cause, it thickens the mucus and inhibits sperm transport. It also changes the endometrium, that is desterilization and glandular atrophy occur. So the implantation does not occur. So these are the two additional advantages of Marina. Skyla is Skyla. See, it's a new thing, Skyla. So already you should know all these things. See, when you heard Marina, you all know. When they tell Skyla intrauterine device with lower dose and smaller frame. So it becomes very easily, it can be inserted. So this is 13 milligrams of releases 6 micrograms daily. So this is what is called Skyla. So you learn Marina, you learn Skyla. Now they will ask you the most common question, and you are all thorough with wherever you want to inhibit estrogen. So there you can put, and Marina is such a wonderful drug for AUB. With the insertions, I will tell you one incident. When the Marina was first came in UK and all, there is not like our places. They don't get easily dates for hysterectomy. So the bleeding has to be decreased. What happened was that my friend was telling me, put Marina for all the patients and give them date 6 months after 1 year and all. 50% of the patients only comes back. Plus 50% will be cured by Marina. So it's a wonderful drug. So wonderful IUCD. So it's AUB, endometriosis, adenomyosis, simple endometrial hyperplasia, not only simple. I'm giving it for even atypical hyperplasia. Atypical hyperplasia. So so they will ask you usually in a young woman with the atypical hyperplasia. Many cases we are seeing now because of the PCOD treatment and all these things. Atypical hyperplasia. I have patients, even doctors. I have 28 weeks, 29 weeks with atypical hyperplasia and all these things. When there, either you can put orally, you have to give very high dose. Medroxyprogesterone or megestrol, very high dose. Medroxyprogesterone, you want to give 200, 160 to 200 means imagine how many tablets. There is no tablet available of 200. You get only 5, 10, 20, 25 and all. So how many tablets you imagine the patient has to take? So what we do is that put Marina. After 6 months, again, we will take samples with the Marina inside pipple is being taken until she may be an infertile patient also. Till the endometrial hyperplasia, typical hyperplasia goes the same, it continues. Once the endometrial hyperplasia is reversed, atypical hyperplasia is gone, then send the patient for IVF, ovulation induction and IVF. So this is how it is managed. So but you have to be very careful. Once there is an atypical hyperplasia, you have to follow up the patient. That is one of the most important. This is the Marina inserted. You all know there is a plunger here. You push it forward first so that this will go inside initially. Then what you then you load it and keep it in your tray. This is the loading part. Then what you do is hold the cervix, take a sound, measure the length of the length of the cavity. Once the cavity is measured, then you adjust this to the length, how much it's 8 centimeter or 7 centimeter or whatever 9 centimeter you adjust. Then you push it inside. Initially you push little above the cervix. Then you release it so it comes out like this. Okay. So it maintains a memory. Then you push it into the uterine cavity, push it up into the uterine cavity. Then it reaches. Then you pull the knob down. So why I told is that you all have to learn how to insert a copper T, how to insert a Marina. See, practical points are very important. When you go out, you don't know how to insert it. You know Marina is being used for so many wonderful things. No use. Next day morning, when you go for a practice, patient comes and says that AUB, I don't need hysterectomy. So you want to insert a Marina. You don't know how to insert. You know only the theory. So basically, you push the plunger up. You say to the examiner, push the plunger up so it goes inside. Keep it on a tray. Hold the cervix. Then you measure the length. Then you put it into the cervix. Just go just above the cervix. Then you open it. Just pull it down like the same way. Pull it down only this much. So this will come out like this. Then you push with the whole thing. You are pushing inside into the uterine cavity. Then what you do, once it reaches the uterine cavity, then you pull it completely down. See, if you pull it initially down, you will lose the Marina. Then you cannot push it inside. So the patient will lose 3,500 rupees and you are responsible for it. So all the small things which you have to learn, that makes difference from. So in postgraduate days, whenever this small, once you see, it's enough actually. So at least take some time to see all these things. Only learning theory is an useless thing. Coming to, see, there are now coming to fourth generation IUS, fourth generation. When you come to the fourth generation, it's called the gynae fix. Here the T-shape has been removed. That is what causes then expulsion rate is very high. So the T-shape has been removed. So it is a gynae fix, frameless copper containing IUS. So when you are asked gynae fix, it's a frameless copper containing IUS inserted into 1 centimeter. It's a plunge 1 centimeter into the fundus. So available in two versions, 200 and 330. Less incidence of bleeding, pain, expulsion, all these things common. So what is the common? They will ask you what is the common cooperative, what is the commonest complication, pain and bleeding. Okay, so that is why everybody has to inform whenever what are things you will tell the patient when the patient goes home after putting a copperty. You have to check the thread, everybody will answer, but you have to tell the patient that next two periods they may have excess bleeding and pain. So you can give her mefenamic acid tablets and tranexamic acid also combination can be given to them for the next 2 periods. So they will not come back. Otherwise, they will go to a nearby doctor and take out that whatever copperty you have put, it will be taken away. So all these things, counseling is one of the most important thing when you do about contraception. This is another frameless IUS. So this is frameless IUS. This is how gynae fix IUS is being kept. Okay, so some places they have the mannequins will be there, and you will be asked to put. So you have to know this is applied like this. Okay, so this is how it comes like, and how to, this is to measure and this is to push. Gynae fix IUS is there. Another thing, modification of Marina is Fibroplant. Fibroplant is a frameless LNG IUS. Frameless, I'm writing once more. Frameless LNG IUS. Frameless LNG IUS. So this is very important. So when you are asked what is it, Fibroplant, it's a frameless LNG IUS. So LNG IUS itself, you so many things you learned. LNG IUS, Kyla we learned with the smaller version of LNG IUS. Frameless LNG IUS, that is what is called the Fibroplant. So it's a stainless steel clip secures fiber to anchoring thread. This is what is it. So effective normally menstruating woman as well as woman with abnormal bleeding. So hemorrhage is there. So this is how it acts, and this is what is called a frameless LNG IUS, what is called a Fibroplant. Okay. Now this is another intra-cervical fixing device. So many things are there. Just for your shake, you learn there's a projection anchored to the inner cervical canal using a modified tenaculum. This is as the better anchoring mechanism and prevents expulsion. So many ways of, so it has an anchoring into the cervix also. So the expulsion rate is less. So till now, you thought that it is a shape of the T shape is the best. Now we are coming out with the intrauterine ballerina, ball, you remember ball, round shape, ballerina, marina, ballerina. So it consists of a spherical shape, memory alloy, nitinol. Okay, even if you don't remember nitinol, it is okay. With polymer of several pearls are there. See, you can see here. And due to the special form, conform the shape of the, it goes into the shape of the uterus. Okay, so risk of damage and irritation is less. Okay, and attached to one of the It is attached to one of the frames attached to two removal strings, allows the healthcare provider to pull it out, like the same property. So this is called the intrauterine ballerina. Ballerina. So Marina, ballerina. Marina was the T shape. Ballerina was like a round shape ball. You remember like that. So now coming to another important topic, which is asked for the postpartum IUCD insertion. Ease of insertion. You need motivation. No extra hospital visit. That is the most important. So easy to insert. You don't have to dial. Cervix is already open. You don't have to dilate. Less motivation is needed. You can, because patient is on table for delivery and she will be, you are taking the delivery. Though she will be, you can anything, she will accept all your whatever you have taken the delivery of a baby, and she is seeing her child, and you can easy for you to motivate her. So no extra hospital visit is there. All of it. First thing, what is the full form of PPIUCD? It is not postpartum IUCD, please. Recently, answer I got from one of the postgraduate in a postgraduate exam. It's a post-placental insertion. Post-placental. The word is post-placental insertion IUCD. So otherwise, it's called the delivery room insertion. How do you do is that when the IUD is inserted within 10 minutes after the expulsion of placenta, so that is what is called a post-placental insertion, or then the same thing, immediate postpartum insertion can be done. Postpartum insertion is that morning after delivery. So if you want, you have to deliver, you have to insert it within 48 to 72 hours. You call the patient down next day and you can insert it. Then comes cesarean. While you do cesarean, you can put it inside and thread to the cervical side. It will come as a uterus. The funniest thing is that even if the thread is not in the cervix, towards the cervix, you keep cervix, it may not be there, but as the uterus involutes, the cervix, the thread will also usually come out of the cervix. Then intraval insertion. So anything intrauterine device at more than 4 weeks postpartum. Only thing you have to remember is that, see, that is what is expected from you, is that not to be inserted. See, you can see not to be inserted after 4 days and 6 weeks. You can see increased perforation and expulsion during this period. So after 48 hours, we don't allow insertion. Okay. So you wait for 6 weeks, 4 to 6 weeks, at least 4 weeks. Then after 4 weeks only you will do. So these are small points which you have to remember. Please, post placental insertion immediately within 10 minutes. Next day morning you can insert. Whatever you do, you should, if you want to insert a PPIUCD, you have to do it within 72 hours. Otherwise, you can do like the other IUD, you have to do only after 4 weeks. So how do you insert? There is a ring forceps is there. See, you hold the anterior part. I will show you after some time. I will show you. See, this is how you hold. See how you hold. Please be careful. See, they will tell you, give a grasper and tell you how you hold. They wanted to know that how you have inserted or not. So you have to keep it like this. You should not put the here. If it is this instrument is available, it's okay. Otherwise, you use a normal sponge holder, then you should not lock it. Then this IUCD will break, please. So you just have to hold it. Do not close the ratchet on the forceps. Just have to hold it. Gentle traction on the cervix, you insert. Once you have inserted the cervix, leave the hand from the cervix. Okay. Then you go to the fundus. Hold the hand on the fundus. Then you insert inside. Touch till it touches the fundus. Okay. Then you leave it. Remove the forceps with an open, like you opened it, don't close it. But if you close it again, it may come out with you. So you open it, keep it open, then slowly you pull it out of the cervix. After some time, after a few days, as a uterus involutes, you will see that after 6 weeks when you examine, the thread will be at the cervix itself. So this is how it is being kept. The hand is kept on the fundus. So all these things are advantages. You can easily say safe and effective, immediate access, safe in breastfeeding, convenient setting, all these things, discomfort and pain associated with insertion. Oh, nothing is there. Potential to reduce rapid pregnancy, repeat pregnancy. See, I told you, I have seen pregnancies within 3 months. So all these things can be avoided. Expulsion rate, higher expulsion rate is there. That is okay. So these are the things which are some disadvantage, you can say. Higher expulsion rate. Counseling is very important part of it. This is postpartum insertion. This is how you push it inside. Now coming to the most important, half part of the class is over actually. Now coming to the most important part, hormonal contraceptives. Okay. Hormonal contraceptives, when you take, the most important hormonal contraceptive is combined pills, COCs, and progesterone only pills. Okay. These are the most important oral contraceptive pills. Hormones, non-oral ways you can use as injectable, implants, vaginal rings, transdermal patch, and hormonal IUCDs, which now we discussed hormonal IUCDs. And you can, and a special session on emergency contraception. This is how we will be dealing with hormonal contraception. Mala N. It's very famous during our time. Mala N was because that's a government supply, free supply is there. Mala N. So we say no cost, N for no cost. Mala N, it's a free supply which is available. Okay. That is N for N is not N for no. I told you to remember Mala N is which is distributed for many of you are from government private hospitals where they don't know what is available in the government hospital, freely given in the PHCs. See, there are different types of, most commonly used is a monophasic pill. See, here the thing is that most of our pills, the estrogen and progesterone is constant throughout the cycle. There is no difference. So you can have either a 21-day tablet like Novolon, Femilon, or a 28-day cycle, 28-day packets like Yas. And I just told some, I am not particular, you use which brand and all these things. You can prescribe any brand you like, but for examples which I gave, so monophasic pills. So when they ask you monophasic, that means throughout the cycle, estrogen and progesterone content is the same. Biphasic, triphasic are developed to reduce the amount of progesterone. So some people say that minor side effects of OC pills are due to progesterone. So they want to reduce the progesterone effect, like bloating, weight gain, so many things which patients commonly complain. Patients are least bothered about cardiac complications, DVT, and they don't know, but they mostly come to us with the minor complaints. So minor complaints are mostly due to progesterone. So they even if you want to use, but not popular. Then the which is coming is extended cycle oral preparation. So they don't have to, we don't have to think we can take it for 72 days or we can take it 365 days. Like that, a classical example is seasonal, where it is a 84-day OC pills and 7-day pill-free interval. We will come to it. I will show you the pictures of all these things. So you learn that there are different types: monophasic, biphasic, triphasic. Monophasic is the most important. Monophasic means the content, estrogen and progesterone content is same throughout. Okay. And we told about the extended oral. So we don't stop at 21 days or 28 days. We stop long 72 days or 84 days, or we take it for 365 days. Classical, some examples I am telling you. Monophasic, Mala N. 28-day pill pack is there. Here, what is there in the 21? Only the sequential, and the 7-day, mostly it will be an inert tablet or a iron tablet is being kept. So they will ask you, they will show you a Mala N tablet and how many days you will take. So we will say 21 days. You open and see there are black 7 tablets are there. So you have to tell that these are our iron tablets for the patient. So patient is taking continuously. Patient doesn't feel. Overall L or your Novolon pack is only 21-day pill pack taken for 21 days continuous, followed by 7 days pill-free interval. The progesterones are of different generations. We will come to it after, but you should understand first generation. That means it is our norethindrone, norethindrol or norethindrol. So all these things are the first generation. Of that, the important, you learn only one thing: norethindrone acetate. Second generation, norgestrel and levonorgestrel. Here you will be all learning levonorgestrel for second generation. Third generation, you know desogestrel. See, at least norgestimate, gestodin, and desogestrel. See, when you go for when you wrote your PG entrance exam, all of the following is third generation, except you had where you used to have we used to write steady norgestimate, gestodin, desogestrel by heart. But when you come to the practically, when you say first generation, norethindrone, second generation, levonorgestrel, and third generation, desogestrel. And then comes fourth generation. When it comes to the word you learn is drosperinone, dinogest, cyproterone acetate, and all these things are the fourth generation addition. In that, drosperinone is the most important, and dinogest. Nowadays we use dinogest also. So first generation northisterone, second generation levonorgestrel, third generation desogestrel, fourth generation drosperinone and dinogest. So this minimum things you should understand. Mechanism of action, I don't want to go into too much details of it. It's all given. It's a very simple theory. But like IUCD, you have to know, because it's a question which is asked usually, how does it act? And the examiner knows that you know this thing. But the most important, OCPL means if you don't say a prevention of ovulation inhibition, that is the most important point. First thing what you have to say. You don't have to say divide it into effect of estrogen. Then the theory, when you write all these things. So inhibition of the mid-cycle LH surge leading to prevention of ovulation. Then suppression of pituitary FS secretion, follicular genesis you can suppress, gonadotropin you can suppress. Then like a feedback inhibition actually. Progesterone effect is in the endometrium, deserialization and eventual atrophy to the endometrium if you give for a long time. So this is the principle when you use for DUB continuously, when you use an AUB, the AUBE or AUBO, where we want the endometrium to be completely atrophied for a long time we give. Alteration cervical less permeable to the penetration, like Marina, this also helps. That is what Marina is a progesterone. That is important. So, an impairment of the tubal motility and peristalsis. All these things are so effect of progesterone. Progesterone, you remember progesterone, endometrium, cervical mucus, tubal motility, and estrogen mainly plays on the hormone level. So you remember that estrogen means hormone. You say any hormone inhibition is okay, but whatever the point you have to remember and point you have to say is it inhibits ovulation. So it inhibits ovulation is the most important point which you have to say. Side effects can be divided into minor and major. I told you most of the minor side effects are due to progesterone, nausea and vomiting, weight gain, mood changes, headache and migraine, acne, hirsutism, breakthrough bleeding, breast tenderness, decreased libido, water retention edema. See, come on. Patients discontinue treatment because of this problem. Okay, you should understand the basic thing. Major side effects which are very important: venous thromboembolism, IHD, stroke, mild elevation of blood pressure. See, there is no hypertension as a complication. Please don't tell hypertension as a complication. Increase SHBG, increase in clotting factor, angiotensin. Liver, it can cause cholestasis and hepatocellular adenoma, not canceroma, hepatocellular adenoma. So these are some of the things which, so all of you should know the minor, because this is what you are going to get. You have given an OCP and the patient comes with all these things. So these are the minor changes that you can have. So all these things you should know. Then only you will know that you have to stop that OCP and give some other methods of contraception. So you have patients, migraine, exacerbated headache and all these things. So when this patient comes, don't send it to a neurologist to deal with the patient. So you should know that, okay, this is what you have started, then you stop it. Weight gain is another problem. See, nowadays I know all of you sitting here, all of you are very health conscious. You don't want to, you want to look thin. So you want to be like Deepika Padukone or Priyanka Chopra and all. So you wanted to be, so weight gain, whenever the first question, like you also ask, you will also ask the same question if I prescribe OC pills to you as a contraception. So these are the small things which you have to remember. Other things like venous thromboembolism, ischemic heart disease, stroke. Whenever you remember of venous thromboembolism, desogestrel, which came as a big way, but it was taken out of market in popularity, came out 90s when I was a MBBS and I joined MD. At that time, desogestrel was used like anything, but later thromboembolism was up. So classical example of thromboembolism is desogestrel. Next is that, next we are coming to method of initiating OC pills. See, there are different ways of initiating. So when will you start? So first is that, okay, Sunday start. So it's very easy. So the patient has come to you first Sunday after the period you start. Patient will always ask you second day, third day, fourth day. Many times you know, first day start. Pill on the first day of menses. So either you can say it's very easy for them. Don't confuse them telling the second day, third day, fourth day. Either you say that it's very simple to say that Sunday start. So I always say, I always tell them that, see, that is the easiest way to say. Start on the first Sunday. After your periods, next Sunday you start. Or you can tell them that you start on the first day. Quick start means, the problem is that quick start means anytime she comes, you start the pill. But in this case, you have to, they will ask you, what is the extra precaution? You have to supplement it with another like a condom or barrier contraceptive for next 7 days. We don't know the ovulation has occurred or not. So, so there are 3 ways of starting it that you know: Sunday start, first day start, and quick start. Okay. So this small point you remember. What are the trends? What are the changes that has happened in the last 50 years of history? What are newer synthetic steroids came? New came. We started decreasing the dose of estrogen. We have come to 20 and 15 micrograms are available. Selective progesterones, as I told you, have reached up to the 4th generation. So once more, you tell me, first generation northisterone, second generation levonorgestrel, third generation desogestrel, fourth generation drospirenone and dinogestrel. So remember all these small things. When we, because I want you to answer after this class. See, specimens I have taken, instruments I have taken, all these things I have taken. So drugs I have taken. So I want all of you to score 100% mark for the exam. There is no, after my class, not even a single person telling that a contraception table went fine to me. I got all the questions in contraception. More than this, I don't think after the class you will understand. More than this, anything is there in the book or net, I don't know. So everything has been taken. Fewer hormone-free days. See, we say that. See, that is why extended regimes came. Longer cycles or no cycles. That you have, I told you 365 days. So these are the changes that has come. So this is the first generation which I told you. Then came the second generation, levonorgestrel. I told you, norgestrel and levonorgestrel. Then came the third generation. I told you, desogestrel, and I put it in red. Increased incidence of venous thromboembolism. There is a common practical question they ask you. Then drospirenone. See, something about drospirenone you should understand. See, why drospirenone is preferred over. So you all know it has got anti-androgenic and anti-mineralocorticoid theory, you know. But what is the basic thing is that you should say there is less weight gain. BP does not increase even for a slight. Acne and hirsutism, even it can be considered as a treatment for acne, they say. Even if it is not the treatment, less acne is there. It can control premenstrual syndrome and decrease hirsutism. On the other side, theoretically, it improves lipid profile. It does not affect the glucose metabolism, does not affect the BMD, bone mineral density, and no increase in DVT. So, thromboembolism, venous thromboembolism, as versus other OC pills. So this is the advantage of drospirenone. So I am sure that you know these things. It is a matter that how fast you will tell all these answers in a or like some 1, 2, 3, 4, like you should say. So on the one side, it's a physical, and I put it in red because that is the clinical examination part. On the other side, it is an investigation part. Okay. So no weight gain, no BP doesn't increase, acne, hirsutism, and PMS. Okay, on side. Other, you say lipid profile better, no involvement in glucose metabolism, does not affect the BMD, and there is no significant risk of venous thromboembolism. So it can be formulations, can be monophasic. This I told you. This I told you. This is the monophasic tablets. You can see. This is what I told you. 7 tablets of iron. These are the different combinations and all these things. You can see what are the combinations. In all these common drugs, Femilon, Novilon, Loyet, Aspirin, yes, whatever common I have seen, I have just wrote it commonly, which is in the market. So one thing is there, everything, one thing is common. See, ethyl estradiol, only the dose has come down, nothing else is there. And you should all understand that in overall G for greater, it's a 50, and overall L low, it is 30. This is what just to remember. If you want to give a higher dose, give overall G. If you want to give a lower dose, give lower. These are all in AUB management. Nothing to do with more than the contraception. This overall G, overall L, and all we use it so much in the AUB management. Okay. Extended regime. See, why you want to extend the regime? Shorter hormone-free interval and similar efficiency. So decrease ovulation, escaping less. Decrease ovarian activity, mid-cycle breakthrough bleeding decreases. So when you are, what is the advantage you are saying is that, see, you may not miss any ovulation, breakthrough bleeding is less, and the withdrawal features of the hormone does not occur. Useful in perimenopausal women because it also helps to control the vasomotor symptoms. So these are some of the advantages why we wanted an extended regime. Seasonal, so available since 2003. Imagine. So taken continuously for 84 days, 7 days break. So fewer periods, only 4 periods in a year. Breakthrough bleeding and spotting are very few cycles. So these are all first few cycles. That is all. Almost all breakthrough bleeding is progesterone containing. Most of the progesterone. Only contraceptives, the commonest side effect when you are asked is a breakthrough bleeding. Extended cycle sequence, seasonic Q. That here for here what nothing is there. Here that pill-free interval is not there. Instead, we are giving low dose estrogen during that period. So no hormone-free interval as such. Okay. So this hypothesis that it decreases the breakthrough bleeding. So these are some of the benefits of extended cycle pill. Okay, relief from dysmenorrhea, menorrhagia, premenstruation, all these are iron deficiency anemia, endometriosis, headache, epilepsy, rheumatoid arthritis, coagulopathy. See, they will ask you what are the extra advantages. All this thing can be told for a non-contraceptive benefits of an OC pill also. Continuous. Okay, continuous use. What do you mean by continuous use? Continuous use 365 days. Okay, liberal. So you learned seasonal, sequential, liberal. So liberal is a continuous use. Seasonal is 84 days. Okay, so at least you know these names. This may be in the market. I have not used personally. I'm telling you, I am also by hearted all these things. But hope that it will, once it comes in your practice, it may be common. After 5 years, all these things nowadays patients are don't want to use. They have so much things to think about it, so much things to work, and so they may prefer something you take it for 365 days without any. So they will not have any problem. Instead 21 days, then break, then period has to come. All these headaches they don't want. Coming to this is you may have with PCOD. So PCOD patients or patients with hyperandrogenism, we take pills with cyproterone acetate. So it is a cyproterone acetate, 2 milligram, 30 micrograms of ethinyl estradiol, good cycle control, decrease hirsutism, good contraceptive efficiency, and effective management. So whenever PCOS patient with contraception is needed, so this is one of the best. And young age PCOS patient, not for contraception, the cycle control also with hirsutism and acne, this is one of the best cyproterone acetate containing pills. Many newer trends have come. 24++. Classical example is a pill named Dronis. 24++. Dronis 20 ethinyl estradiol and one of the Dronis is there. Like if a latest estradiol, valrate, and Dynogest, then they mix with the Dynogest with. So this has also come in the market. Dynogest with ethinyl estradiol has come in the market. So many different. This is what now new thing which has come in the market. So this is all in the market actually. And they even say that this can be given. I don't know. I agree. This is a good drug for contraception. So they say that as Dynogest is kept, they say that it will be useful for endometriosis with a combination with ethinyl estradiol and Dynogest. I don't know. But so many combinations are now coming up. Mifepristone is there. Orninoxafen is there. We'll come to orninoxafen after some time. So this I told you, use backup quick start method, use backup method for contraception for 1 week. Now certain controversy things. OCP, and you will ask in the exam. See, what is your view with the OCP and blood pressure? Okay. See, one thing you should understand that low dose OCP pills rarely. So it will not cause clinically significant hypertension. And there is a belief that if you use OCP, patient can have gestational hypertension. That is also wrong. Okay. Then contraindicate a hypertensive patient. See, OCP doesn't, but in it is contraindicated in hypertensive patient. Why they will ask you? Because there is increased incidence of MI. That is the reason. So hypertensive below 35 years non-smoker, no end organ disease, no other cardiovascular, well-controlled hypertension, COC can be started under careful. So can it be given? The question comes, it can be given. So the question is this. Otherwise, it is contraindicated in a hypertensive patient. So don't answer that OCP causes hypertension, but OCP is contraindicated in a hypertensive patient, especially hypertensive, and risk of MI and stroke increases. So here, what will you give? POPs are progesterone only methods will be safer. Anyway, whatever way you want to give, you can give. Another thing which is asked for the exam is, what is the role? Can it be given in endometrial? Can it be given cervical? Can it be given? So you should have, these are the studies which have come. In endometrium, it is considered to be protective. Okay. If you use it for 12 months OC pills, they say 50% risk reduction is there. So, and this protection persists for 20 years after discontinuation. That is what they say. Epithelial ovarian malignancy also, it is sure. See, there is no confusion in it. It is protective, and even we give OC pills and advise OC pills for familial cancer syndromes and all. If you take OC pills, it gives protection. Colorectal cancer also, it doesn't cause, it is protective in colorectal cancer. Coming to CA cervix, okay, very controversial. See, some studies have shown there is increased risk, okay, with continuous use. Okay, CA breast, another thing. See, in increase in, there is a current use increase in early menopausal cancer, but risk disappears after 10 years of use. There is no, in a long-term use, there is no risk at all. But in a known case of CA breast, OC pills are contraindicated. Like in a hypertensive patient, OC pills should not be given. In a CA cervix female, OC pills should not be given. So will it cause CA cervix, CA and cervix, or CA endometrium, CA breast? Sorry. So protective side, you can answer CA endometrium and CA ovary. Causative side, you can, if they ask, exam is insisting, then you can say CA cervix. If the immediately examiner will ask you, are you sure? And you say that different studies have shown it is controversial. So there is some, see, pap smear changes have been observed actually. That is why, based on that, we say that, yeah, but actually no significant increased risk of invasive cervical cancer is seen. But based on these pap smear changes, these studies have shown that, okay, increased risk of changes are there. So this is what is. And this I'm not going to detail. It's so much to see. Today, homework for you is that you have to see the WHO eligibility criteria. See, this can be asked as a short note for DNB exams or whatever. Other exams are over. Our exam, state exams is over. Now it will come after 11. So everybody prepare a short note on. And the latest version is there, 2020 version is there. So you can click in the net, it is there. Every details is there. Updated recommended based on current evidence to provide guidance of safe contraceptive services to address the special needs. So there are, it is been, points are there for each contraceptive. So category 1, 2, 3, 4. If they ask you what is category 1, means for which there is no restriction on use of this method. One you can use that method in that condition. When the advantage generally outweighs the theoretical or proven risk, they say 2. When the theoretical risk or proven risk usually outweighs the advantage of using the method, that is 3. Risk is outweighing the advantage. The 2 was advantage outweighs the risk. And the last is unacceptable. Okay. So this is, so what are the categories you ask in the exam? Everybody should know. It looks simple, all these things, like our ABCD for that research. Here, category 1, category 2, category 3, and category 4. So 1 is, you can use it without blindly, you can use it. 2 means advantage outweighs the risk. 3 means risk outweighs the advantage. 4 means it is unacceptable. Okay. And this is what A, B, D, S, another thing. So accept, caution, delay, and special circumstances. These are another criteria, various medical conditions we write. And it is a wheel is there. You rotate the wheel. Please see, it is so nice actually. If you have this wheel in your OP room and you rotate this wheel, see, this wheel is kept for exams actually. So this wheel will be kept. Ideally, it should be kept for the exam. Every postgraduate should know such a wheel is there. So if I am an examiner, I am going to take a wheel and bring with and keep it in an examiner as for the exam, show you. And The advantage, you don't have to learn anything. So patient comes, patient tells hypertension, you turn it like this. Patient non-smoker, you turn. And then you can say, okay, OC pill cannot be given in this case. What are the recommend? Immediately it will show what are the things it can. One for one, what are the which can, what are their preferences are there. You don't have to by heart anything. So such a wonderful wheel is there. Then one common question, I put it in red actually, which is asked for the exam. How long pills can be given? So how many years you want continuously without any increased risk. So pill, there is no restriction. It can be given how many years you want. In Western countries, they take from puberty to menopause, the pills, because their sexual habit starts very early. So when they are in 8th standard or 9th standard or 10th standard, whatever, whenever. So they take it for a long time. So it's for a newly married couple, or this is the best protective actually. That is why. Now coming to a non-oral hormonal contraceptive, very common another thing, Depo-Provera. Okay, what is a Depo-Provera? DMPA injections. Okay, DMPA. I feel that I cannot ask anybody. I feel so sorry when I take through the. I don't like taking through this Zoom platform, because my students sitting next to me, discussing with them, answering, asking them what are the questions which they want, clearing their doubts. It's an entirely different way of doing it. So here the problem is that I am telling something, I am only revising it. How many of you are listening to the class? I don't know. Listen to the class. That is more important. Okay. Injection DMPA contains 150. Okay. In 1 ml, it is an IM injection. So 150 milligrams. Where do you give? Upper arm deltoid or buttocks gluteal or thigh anterior outer thigh? Usually given deep IM. Mechanism of action. See, as it's a progesterone, like all progesterones, it changes the cervical mucus, ovulation image, and make endometrium unreceptive. So this is by heart for all progesterone only things. Failure rate is 0.2% and 6% for typical use. How to start? Okay. In a lactating mother, to start at 6 weeks, you can inject at 6 weeks. Non-lactating, to start 3 weeks after delivery, immediately after 3 weeks after delivery. Menstruating woman within 7 days of menstruation, no backup method needed. If after 7 days, as I told you, the same way, OC pill starting late, that is means when you use the quick start method, anytime during like that, you have to use a backup method. So you don't know the ovulation in that cycle has occurred or not. So this is about, and this has by different names it is available. Advantages is estrogen is not there, so estrogen side effect is not there. Best in lactation, because estrogen is not there, it doesn't suppress lactation. Coming to endometrial and ovarian cancer risk can be diminished as a progesterone. Relatively less effect on lipid metabolism, blood sugar, same thing what we told. Okay, and liver function. Disadvantages is that as breakthrough bleeding, all progesterone drugs and weight gain, even if I have not written weight gain, these two things you commonly see in case of, so two common things. And the problem, another problem is that in a copperty, when you take immediately, the patient fertility returns. Here, if you are taking injections, return of fertility, withdrawal after withdrawal takes about 8 to 9, minimum 6 months it will take. BMD is decreased due to hypoestrogenism. Prolonged hypoestrogenism can cause bone mineral density, can decrease, and osteoporosis if you take it for a long time. Other problems, progesterone, weight gain, I told you. See, I am very concerned of this thing, because many of my patients initially has come with a weight gain and mood changes and all these things. So breakthrough bleeding and weight gain are too common. They ask you what's the common things: breakthrough bleeding, weight gain, present. These are the common things. Then you can say this fertility returning after 8 to 9 months, and hypoestrogenism causing bone mineral density. What are the non-contraceptive benefits of DMPA? So it can be used for a treatment of dysmenorrhea, prevents PID, endometriosis. It can be given, protects against endometrial cancer, and improves anemia naturally. For all hormonal contraceptive which treats AUB, it can improve the anemia. This is new medroxyprogesterone. It's called the Cyana Plus. See, the problem of medroxyprogesterone, deep IM, you have to go to the hospital. It is very painful injection, and all these things are another disadvantages of taking people. Now we have Cyanopress. It's very simple. DMPA, it is here, it is not 150, here it is 104 milligram, subcutaneous injection. So it is, this is available, and this will be kept for the exam. A PG exam now should be kept because we are using it. So without this Cyanopress, don't go to the oral contraceptive table at all. I'm telling that this will be asked for, this will be kept for the exam, especially those who are going for DNB exams to an outside hospital. There are the pattern of contraception used in different. If you are going to some cities, see, many of your DNB exams centers are in major cities. So when they go in a corporate hospital, so you are going in exam in Apollo hospital or major hospitals, all these new things will be there. For them, they are using it daily. So for the examiner, HOD in that hospital will think that, hey, you don't know this Cyanopress. Maybe you are coming from a small hospital, DNB in a hospital where you are not using this. Maybe your patient cannot afford all these things. So, but you should know all this. So tomorrow, today itself, you should know the needle is smaller than IM, pain is less. And there is, whenever there is a bleeding diathesis or a risk of hematoma is there. So very simple, patient can take it herself. Now, 2 injections we told, it was only progesterone only injections. Now we go for cyclophem and mesigna. These are the 2 things which are the combined injection. So what do you mean by cyclophem? Cyclophem is a combination of medroxyprogesterone acetate and estradiol cypionate, while mesigna is a combination of northisterone enanthate and estradiol valerate. So it's a combination of estrogen and progesterone given 28-day interval. It's not 3 months. It's given 28-day interval intramuscularly. Actually, it is not available in India, but you are safe that somebody has to bring from outside. So many of your consultant goes outside. See, we take all these things and come. So when we go for a FIGO conference, when we go for any other conference, when you go to the stalls there, they will be. So we take it to show to our postgraduates. Sometimes what happens is that postgraduate themselves may put it inside the tray, and finally it will come to their exam itself. So this is not available, but maybe in some hospitals picture or there, even some hospitals they keep the take printout from the net and keep the name, that box name, like this box will be taken and kept it as a picture in a this is especially we see it in OSCEs and all these things, and then they can ask questions on it. Contraindication of injectable contraceptives is unexplained vaginal bleeding, known or suspected pregnancy, known for suspected breast cancer or history of breast cancer, known or suspected so breast cancer, and we told. So any other things, thrombosis history is there. That are the only things which are the contraindication for this injectable contraceptives. So other contraindications are also written: diabetic vasculopathy, ischemic heart disease, severe hypertension, thrombosis, hepatic tumor, and active liver disease is there. Better not. Now coming to injection, now coming to implant. So we finished injections. So non-oral injection. So what we learned injections, we learned progesterone only injection. So we DMP and Cyanopress we learned. Then we came to estrogen progesterone combination. We learned cyclophem and mesigna. Okay. Now we go to the implants. So injections are over. Implants, one of the commonest implant, what we say, it's a Implanon. See, why I put these things, this is out of market now. At least if an examiner asks you, now what is available is Implanon. But examiner, have you heard about Norplant? Okay, you have heard. 6 capsules, 5 years, all these things, 2 rods. Deadly is 2 rods. Norplant 2 it is. So, and coming to, so that is not there now. In your exam, they will keep a cover of Implanon. Okay. Implanon is becoming popular. See, because we are now getting trained by the government to put Implanon. In northeastern, that is like in oriental countries, it is very famous, like Indonesia, Malaysia, Thailand, and all these places. This Implanon is very famous. I will tell you a small incident of Implanon. A patient from Philippines came years back, happened. it came to my OP and told me, see, imagine my ignorance. See, we are not using it. But she came, I told, what is your complaint? I don't have any complaint. I came to remove the Implanon. Then I told, okay, where is the Implanon? Then she showed me the hand where the Implanon is kept. And I don't know how to remove it. I have not removed it. So luckily I got so confused. So I was having a madam near my another hospital near who had come from UK. So she told that, okay, I will remove it. I have that Implanon, how to remove a hook also. I have removed it. So she told me that you have to palpate it and take a small incision and take it out. Most of the time you may not be able to visualize it also. Okay. So future, you should know all these things. Okay. So it's a single round. It contains 3 ketodesogestrel, while all our Norplant was containing levonorgestrel. Basically, I'm not going to now how does it act and all these things. Now you should know. Progesterone only, ovulation inhibition, increase cervical mucus, endometrial hostility, and these are the things which you have to know. Inserted subdermal inner side of the upper arm, they say non-dominant arm. Non-dominant arm. This is Implanon, which how it looks like with the obturator. You can see this when you, as a lack of time, I'm little going fast. This is her non-dominant hand. Ours, maybe I'm a right, she is a left-handed person. Okay. So usually it is kept in the basipital groove. This is the biceps and this is triceps. This groove where it is being kept. So this is how it will be inserted. It is not radiopaque. So similar to the actions are all similar to OC pill, effective for 3 years. Okay. Inhibition, maximum concentration after 4th day, the concentration is maximum. Inhibition of EC insertion and removal during lactation. So all these things is improved dysmenorrhea. Efficiency is same as OC pills. Same thing, decrease all the same weight gain. All these things are there. Other and it has some side effects like irregular bleeding, acne, decreased bone mineral density, and all these things are some of the other side effects. So so you have, hello, Srilata madam, you are there, madam?
Yes, yes, I'm here. I'm here.
Okay. Suddenly, I thought that my connection has gone. No. In between, I will call you, madam. Okay. So just to make sure that I am not talking to like without you are all there, I just wanted to make sure that is only thing.
No, doctor. If anything is wrong, definitely we will inform you at the same time. Carry on. No problem.
Okay. Thank you, madam. Thank you. So Implanon, it starts within 5 days, day 5, and so you can start within day 5. Okay. Rod removal, palpate, 2 cm. I told you, pop out technique, press it, and then there's a hook like thing, you can pull it out. So not palpable, you have to do USG or under guidance, USG or MRI has to be done. This is something called newer version of Implanon, Nexplanon. Since it is, the advantage is that it is radiopaque. So small things you should understand. See, it is long acting reversible contraception. I told you which is the best is copper T. This is a so progesterone containing device inserted subdermally into the upper arm, local anesthesia. I told you, replace Implanon. So Implanon in US market. It also contains 68 milligram covered by a ethylene vinyl acetate polymer. The most important point which you have learned is radiopaque. So they say that what is the advantage of Nexplanon or Implanon? Only one advantage, radiopaque. Rest of the things you can say the same. Method of insertion, I told you, method of removal, everything is the same. And advantage is that the bone does not, the other Implanon, there is a decrease in the bone mineral density, or like DMPA, there is no reduction in the bone mineral density, and return of fertility occurs immediately after withdrawal. Okay, so insertion and removal is easy if you are trained. So these are some of the advantages over DMPA. DMPA looks attractive, but it has so many problems. So it's a time that so many minor and major problems. So you learn 2 things. There were Norplant 1, Norplant 2, which is better known as Jerdley That is, leave all these things now. It is not used. You learn only Implanon and Nexplanon. The advantage of Nexplanon over Implanon is it is radiopaque. And implants generally are better, less effective, it does decrease in bone marrow density compared to DMPA. And return of fertility is faster. I don't say immediately after withdrawal theory, but faster than the DMPA. It takes long time, DMPA, return of fertility. Okay. This is another low-cost variety of Implanon, which is in implants, which was introduced in sub-Saharan Africa. Now coming to another oral Sencromin, Chaya. It is an Indian. See, we are proud to have something which was discovered in India itself. Our research lab, CDRI, Lucknow, as introduces. This is basically a serum. It contains ornithine. Actually, we are not. I am not using it to contraception, but I am using lot of. It's otherwise called Sevista, which is being used for AUB. So when a patient wants treatment for a long time, like a headache for you want to send the patient off. Patient is coming, so give ornithine, and so what you do, it is taken twice a week for 3 months. Then ask them to take once a week thereafter. Patient may be taking for a long time. Sometimes they come with later, they come with thick endometrium and all these things later, some patients, but you can take it for a long time. The first pill should be started on the first day and second pill after 3 days. So this is how it is done. The prevents implantation. That is the principle of Sencromin. Now it is, previously it was comes as Saheli. Now it has comes as Chaya. Chaya. Now it has comes as Chaya. So remember all the small words. So this is also for DNB students who travel to other cities. For nowadays, I don't know, Corona, your exam is how it is conducted. But if you are traveling to this Chaya, there are places in India where they are using ornithine like anything in the treatment of AUB. I know. So when I went for a talk, and I was not, because I am not using it so frequently for AUB, even AUB, so other drugs I was using. So in the talk, I gave less importance to. Then one doctor stood up and told that, see, we are only maximum we are using is or Sevista. And you have not mentioned about Sevista. They had so many doubts about Sevista, and because I had not read properly about Sevista, I became so much embarrassed in front of them. And they only answered they asked the question and they answered the questions. So they changes the practice, changes of contraception, changes from area to area, even in India itself. So it is not the practice which we follow in Kerala, it's not the practice which we follow in West Bengal. So there are some common things, but the popularity of certain things will be different in different parts. I told you, in Oriental countries, no Implanon is used. Most of you, I have seen only one Implanon patient coming, I could not do anything. But many of you would have not seen an Implanon at all in certain patient. So that is how, so in the future, you will all get trained to put Implanon. So take pill as soon as she remembers. If the pill is missed, it's the same with pill is missed. Same with the OC pill also. You miss one pill, next day you take 2 pill. Miss 2 pill, next day you take 3 pill. But if you miss more than 2 pills, then better to stop that and start a new pack. Then they will ask you vomiting. If you have vomited, after vomiting settles down, you take 1 pill, or the next day you take 2 pills. So this is the different ways in which you can take. If the pill is missed by more than pill is missed by pill is missed by 1 to 2 days, lesser than 7 days. You see, that I be told. More than 7 days, women need to start that. All these things be told. Then coming to another is a Nuva ring. It's called the Nuva ring. So Nuva ring is a combination of, this is a vaginal ring with both ethinyl estradiol and etinogestrel. Progesterone is etinogestrel. So how it is done? You keep it for 3 weeks, then remove that ring for 1 week. Again insert for 3 weeks, remove that for 1 week. This is, the action is same as, mechanism of action is same as use. So you learn in your exam, you learn one mechanism of action for progesterones only. So it is common for progesterone only pill, implants, progesterone only injections, everything common. Okay. Then you learn mechanism of action for OC pills. So that is for all combined, it is pill or ring or patch, or when it is combined, the mechanism of action is same. So by heart like that, it's very easy. Here, the rings are kept, daily compliance is not needed. You have kept it for easy to use, and this is available. Say this will be there for your exam. This is available. Disadvantage is increase naturally. Infection, expulsion, unscheduled bleeding, and all these things can be there. Aloe is another thing with a combination of segestrone, acetate, and ethyl estradiol ring. So 1 year reusable device. So after 1 year, again you can use the same thing. Otherwise, every month you get it. Here, the advantage is that 1 year you can wash it and use it again, sterilize it and use it. This is how it is being inserted. This also patient needs motivation, and how you have the same way you fold it like this, and the same way you insert a pessary. That is the same way you have kept. Go to the posterior fornix and push it under the pubic symphysis. This is a patch. Patch every week you have to put a new patch. After 3 patches, you stop. 3 patches you stop. 1 week patch-free interval. Patch has a waterproof layer, active layer that is medicated. And so above will be waterproof. So even if you with the patch, you can take bath, no problem at all. Greater compliance, less nausea and vomiting. So these are the places where usually patch should not be kept over the breast and all. Patch, upper arm, upper torso, buttocks and abdomen. These are the, so where patch should not be applied over the breast. Okay, irritation over the patch or displaced by sweat, and it can get displaced, and it can cause venous thromboembolism in obese patients. Now coming to the reaching the last part of it. So we come to I-pill. What is I-pill? So emergency contraception. I-pill is an levonorgestrel pill, 1.5 milligram single dose. Within 72 hours you can give. So there are so many. So it can be 2 ways. It was there. I-pill is this. Before that, Plan B was there, where they used to give 2 doses, 12 hour early, levonorgestrel 0.75. The commonest what we use is that I-pill, which is given 1.5 milligram single dose within 72 hours of intercourse. Emergency contraception, you should know what is an interceptive. It's an interceptive. It does not interfere with fertilization, but act on the blastocyst. So this is how an interceptive is different from a contraceptive. So emergency contraceptive is an interceptive. So another, please, interception, another word you have to learn. So whenever you are asked, the interceptive word will come into the emergency contraception. So all these things are there. See, it cannot be used as an ongoing method of contraception, because you cannot use every time. You see, every time intercourse, take 1 pill. That the failure rate is very high, and high irregular bleeding. Even many times what happens, you advise the patient to take this interceptive or emergency contraceptive pill, I-pill. What happens is that next month the period gets automatically delayed. So the patients are so much afraid. They will be continuously doing the pregnancy test, thinking that they have missed period, now failure. And I have seen patients coming with pregnancy after taking emergency pill, contraceptive I-pill also. So different methods we told, emergency contraception, that old method, USP method and all, I am not telling. Now basically we use the levonorgestrel method. Okay, this was the old USP method, 2 tablets, and after 12 hours again 2 tablets. So this is the old method. Okay, nowadays it is not used. And antiemetic taken an hour before the first dose, because if you take it and it vomits, then no use. If vomiting within 2 hours, take 1 more tablet. So only that is the only way. There is no medical contraindication to the use of LNG contraceptive pills. Okay, this is what is the LNG. I told you 2 ways it can be given, 2 doses, and you can give it as a single dose. Plan B, I told you 2 doses can be given. Then coming to mechanical. This plan B is the same as our 1.5 itself. Okay, the same thing. Plan B, it is the tablet which is available in US. I-pill is available in our country. So that is the only thing. So how does it act and all these things? It is written here. No effect on fertilization, only on implantation. That is the word interceptive. That is the word, please. Today you learned that interceptive in emergency contraception, that is enough. Use BO in the whatever method you have. Then you have the mechanical methods, and you should all know that copper T is used up to 5 days. That is the two things. You should understand. So these are the mechanism of action is the same. Aseptic inflammation in the uterus and prevents implantation. The same of all copper T. Then advantages. Advantages. Continue as an ongoing method of contraception. The side effects is bleeding, pain, expulsion, and pelvic. Contraindication is that pelvic infection, DUB, suspected pregnancy, nullipara, and the same thing what we learned. Then when it comes to emergency contraception, mifepristone can be used as an emergency contraception. So it acts in different ways. It can be an anti-implantation agent, that it can be used post-coitally. Menses inducer luteal phase. We use it as abortifacient in early pregnancy. So single dose of 10 milligram within 72 to 120 hours. That is what. So mifepristone is another tablet that can be given as contraception. Okay. Emergency contraception. And Ila-1, it became popular. Now it again became unpopular due to the hepatic side effects. Hepatic side effects. So I still remember 2 years back, I used to use write it for fibroids, and I was very happy with ulipristal with fibroids. The fibroid size used to decrease, and in cases where large submucous fibroids and all, I used to give ulipristal, so its size used to decrease, and then I used to easily do 5 centimeter submucous fibroid. I have given ulipristal for 6 months, and then I have done hysteroscopically very easily because it decreased to 3 centimeter. So, but now it is not available, and it has been contraindicated because of its hepatic side effects. Even if you are given, anybody who wants to give also, they have to check the LFT before and 3 months after giving. Okay. Coming to the last part about sterilization. I will finish in 10 minutes fast. So see, it has female sterilization, if you are asked, which is the commonest method of contraception followed in India, Indian population is female sterilization itself. Okay. So female sterilization, here also it shows that there is a reduction of 30%. See, salpingectomy, you would have learned with ovarian malignancy. So we all all theories, we all know stick theory and all these things. See, where we say that the fallopian tube, from the fimbrial end of fallopian tube, the origin of the fallopian ovarian carcinoma, epithelial ovarian carcinoma. So when you cut the fallopian tube, it gives advantage. And when you want to really cut, you have to do salpingectomy, not just a sterilization may not affect, I don't know. It will decrease the only thing, it will decrease the irritants like talc and all these things going from the vagina to the ovary. So talc is considered to be one of the causative agents of epithelial ovarian. So that causative agents may be blocked, but really if you want to block the cancer, ovarian cancer, you have to do salpingectomy, full salpingectomy. At least the fimbrial end has to be removed. So they will ask you in the exam, the fimbrial end has to be removed. So these are the advantages and disadvantages. Nothing much, things which you know only is written here. Now coming to see, these are the we know where it is done. So all of you know that it is the isthmus. What is a place to do? So simple question: where will you do the sterilization? It is done at the isthmus. Then next question is the timing of sterilization. So things are simple, but all of you just listen. See, after 24 hours to 7 days of delivery, preferably between 48 hours to 48 to 72 hours we can do up to 7 days. Interval sterilization means non-pregnant more than 6 weeks or within 7 days of menses. Then you can do post-abortal sterilization, and say along with cesarean, I told you, along with abortion, you can do sterilization. Then very important, laparoscopic tubal ligation. They will ask you when it is not recommended and when and all these things. So mainly immediate, the question commonly asked is that it is Indian, as you should understand that immediate postpartum. See, I am a laparoscopic surgeon. I have been doing laparoscopy for many years. That doesn't mean that I can say that, okay, I will be doing immediate post. I had referred cases from outside where ring was applied immediately after delivery and patient came with hemoperitoneum. And I had gone again with laparoscopy and coagulated or salpingectomy has been done. So as such, they ask you why it is not recommended in immediate postpartum period. Immediate postpartum period, tubes are edematous, and when you put the fallopian rings, it will cut through. That is the reason why it is not used. So case selection, you should understand, married, at least one child, above 1 year, sound state of mind, mentally ill patient, psychiatric and legal guardian should be there. So which are the things when you delay procedure, suspected pregnancy, you have to make sure that. So whenever you have a habit of doing, whenever a patient comes for interval sterilization, lap sterilization and all for you, you should have the habit of writing a pregnancy test before. So patient don't see about the periods coming and going, and preferably after periods we do, but do a UPT, and then only whenever you are in doubt, nothing will be happen. You wait for 14 days more. Okay, next period, ask the patient to come after the next period. So delay within 7 to 42 days, we don't do at all postpartum period. Not only no sterilization is done. So active pelvic inflammation or peritonitis, PID, all these things, complicated heart disease, anemia, psychiatric disorder, all these things, take a screenshot of these things. You can read it afterwards. So surgical approach, when you go to the surgical approach, you can say that, okay, mini laparotomy, laparoscopic sterilization, vaginal tubal ligation is there. Previously it was done. So at least you should know that you can do tubal ligation to the vagina. Previously it was done. Hysteroscopic sterilization. We will come to hysteroscopy after some time. We will tell you some of the points. See, this is mini laparotomy, postpartum. It's otherwise called the interval sterilization. Interval sterilization, when you do, say, what is the difference of incision? In a postpartum sterilization, when you do, it is done just below the umbilicus. In an interval sterilization, you have to do above the pubic symphysis. I still remember as fresh MD, I came to Thrissur Medical College. So the PPS day is there, PPS OT is there. The PPS OT, when good house surgeons are there who work well, we give them one chance of, before going, one chance of first. So one of my house surgeon was so much enthusiastic. What she did was that she did not ask the patient. Always we say the patient to empty the bladder and come to the, without emptying the bladder, she put the incision. That was the first time I saw and sutured the injury of a bladder. First time in my life. So it was, so I remember, after that I remember that whenever you want to do a mini lap sterilization, you should empty the bladder. Void the urine. Empty the stomach when you are doing, always when you are doing, the stomach is full. That is for laparoscopic sterilization. You do it under local anesthesia. Pre-medication can be given. Uterine manipulator, you lift it and 2 to 3 centimeters suprapubic incision, and you put your hand inside and just sweep it like this. So this is how it is done. So all these things which I told you how to do a postpartum sterilization. Everybody sitting here have seen postpartum sterilization. I don't waste my time. There were different methods also. Everything is in your book. See, each method I will show you. Making a loop and cutting, that is called the Pomeroy's. Just cutting a piece of it. That is what is called a Parkland. Just cutting a piece of it. See, this is what is a Parkland. Madliner, you crush it, okay, and then ligate it. That is what is many people do, that Madliner technique. Fimbriectomy, you cut the frim. Irving's means reverse. You remember like this, reverse. You reverse the tube and then bury it into the myometrium. Uchida means you bury this medial end, cut it and bury it in the mesosalpinx. So Uchida is burying in the mesosalpinx. Irving's is reverse the tube and bury it into the myometrium. Fimbriectomy, Cronus fimbriectomy. Madliner is crushing and ligating it. Parklands is taking a piece of tube, and Pomeroy's is taking a loop and tying it and cutting it away. Okay. Now, see, we told about fallope rings. Other thing which you should understand is tubal occlusion with rings and clips. Okay, Halka Clement clip. Okay, the advantage is that it destroys only very small part of the tube. So they say that if the patient the future requires recanalization, best is, because the damage with the least damage is with the Halka Clement clips. Okay, Halka Clement clips. This is the Filshy clip applicator. Filshy clip applicator, you can see clip is being applied. Titanium, it's made up of titanium lined by silicone rubber. So it doesn't cause too much trauma to the tubes. This device are less effective and when used immediately postpartum in a dilated tubes. So both Filshy clips and fallope rings don't answer in the immediate postpartum period. Can it be done? It can be done. Anything can be done. Understood? This is the fallope ring is being applied. Okay. So the rings and the fallope ring is elastic fallope ring. That is what is called 2.5 centimeter tube is taken, a vascular loop, and you can cut it and send it for pathology specimen if you need. So no need also 2 to 3 centimeter. And common complication, it can have a mesosalpingeal bleed if you are not careful. Okay. Hysteroscopic sterilization. So this is an Assure. There are two things. Assure and Adena is not a hysteroscopy. You can put it through the Assure is a hysteroscopy. So through the there are certain, this Assure ring is being inserted into the tube through the hysteroscope. So the what happens is that it's a permanent. You cannot, it is not reversible. So Assure is not reversible, and the tissue grows in between and it permanently seals off the tube. That is what Assure. And it's a this is the Assure system which is passed through the hysteroscope and into the ostia. It has been inserted. So this is the Assure system, Assure procedure. It is not reversible. So this is the most important point. Should be Assure micro insert. That is what inserted. Patient must use another form of birth control for at least 3 months, because till the tissue grows in between, this patient should have. So this is coming to non-scalpel vasectomy. Two things which you should, it's very simple technique. Two things is that the ring clamps and the dissecting forceps. So two things which are used commonly, ring clamps and so dissecting forceps and ring clamps. You make an incision mid raphe, take it out and cut it and push it inside, tie it and push it inside. This is what we do. This is a very simple technique. No anesthesia needed, only local needed. Patient can go home easily. And only thing what is advantage, they say the hematoma incidence is very less. Whatever you do, you have to use it for 3 months, backup method. Okay. RISUG, this is a VAS stapler. These are the different male methods which we told, RISUG male, these things. And one thing I can show you, this is an intra-VAS device. Into the VAS, this is being implanted into the VAS. This is the last slide. So the sperm is blocked and reabsorbed by the body. So thank you, everybody. Thank you once again. Thank you, Sreda madam. It was 2 hours. If you went on to 2 hours,
2 hours,
I have covered. I have covered whatever possible, madam. Nothing much is there. Whatever in new developments are there.
Not left anything. I would say it's so exhaustive. Dr. Aswath, only you can do this, I think. Nobody else could have done such an exhaustive coverage.
So that everybody, this is all not only for the practical, see, it's for the practical exam as well as for the practice in future. They should know all these things are there in the market. So much changes are taking place in the market. So every day newer and newer contraceptives are coming. So they should have a knowledge. And the funniest thing is that common people knows much about all these things. When they come and sit in front of you and discuss about contraception, and they think that you are not knowing this. See,